listening to the heart, and all you hear is a constant murmur, okay? And washing machine, you know, I guess it sounds like a washing machine depending on what your washing machine sounds like. I'll try to play what it sounds like on Monday. Washing machine, yeah, you can use your imagination to say that. All right. And the hallmark of tetralgia flow, like I said up here, severe cyanosis. So everywhere, every mucous membrane you look at, you see cyanosis. So very congested, very dark. You know, the gums, the vulva, everywhere you look is very cyanotic. And because you do have a ventricular septal defect involved, you know, pan-systolic murmur, palpable cardiac thrill as well. Okay, so you notice this phrase recurring with this. So yeah, ventricular septal defect. But to help you differentiate it, the animal is also severely cyanotic, which should lead you to suspect that there's more than just a ventricular septal defect present. All right, everybody got that? All right. So this is what helps you to be a clinician, to know the subtle differences in clinical signs, and that'll help you to come up with the correct diagnosis. Ventricular septal defect, you know, pan-systolic murmur, cardiac thrill, but with the addition of cyanosis, you know, severe cyanosis, that should lead you to suspect more than just a ventricular septal defect, that there could be other defects as well, and probably a tetralogy of Fallot. So as far as your diagnosis of these conditions, ventricular septal defects and PDAs and tetralgia of Fallot, basically the clinical signs. Remember we're talking about developmental diseases that occur at birth or that present with clinical signs shortly after birth. So when you're reading a case description, it's going to be talking about a young animal that's showing these clinical signs. ClinPath doesn't really help you to differentiate between these three conditions. It's mainly going to be your clinical signs, and also radiographs may be able to visualize it. Echocardiogram may be able to visualize it. You notice the note here. It's actually hard to visualize directly, a PDA. You'd think it would be easy, but it's really not. You have to play with the angles, and you still might not see it. Angiocardiogram would be definitive. Inject a dye and see where the dye appears. As you can imagine, this is a little bit invasive, expensive, and most of the time you've already made your diagnosis of a PDA without having to do the angiocardiogram. Let's see. And as far as treatment, no treatment, surgery, no treatment. So not too satisfactory from a treatment standpoint, but at least you've made your diagnosis. If it's a valuable animal or there's an emotional bond, you can try to keep it around for a while, but you have to tell the owner that there is going to be a guarded to poor prognosis. And probably the best thing to do would be to euthanize the animal, because you don't want it to be, staggering around and being very lethargic and weak and unable to feed and basically starving. So once you make this diagnosis, there's going to be a very guarded to poor prognosis, and you probably want to discuss euthanasia with the owner. Small versus large ventricular septal defect, fair to guarded prognosis, moderate to large ventricular septal defect, poor prognosis. Practically speaking, it's going to be a guarded to poor prognosis, whether it's small or large. And the tendency is for a small ventricular septal defect to develop into a large one. So by the time you make these diagnoses, whether it's for the ventricular septal defect, the PDA, or the tetralogy of Fallot, you're going to want to discuss euthanasia. All right. So was that clear to everybody? The other two diseases that we're going to look at is atrial fibrillation and ventricular tachycardia. Atrial fib versus VTAC. Atrial fibrillation, ventricular tachycardia. And the reason we're focusing on just this handful of diseases, number one, time, and number two, these are the ones that you're most commonly going to see in ruminants. All right. So with atrial fibrillation, so with both of these, there's interference in the conductivity of the electrical impulses through the heart. With atrial fib, there's a lack of coordinated atrial electrical activity, so that's pretty self-evident. Atrial fibrillation, so the problem is originating in the atrium. Caused by abnormal impulse conduction due to unidirectional conduction blocked and random entrant activation of the atrium. All right, love those scientific words, right? So when you're breaking it down to the owner, you're just going to tell them that the electrical impulses in the heart, instead of going in one direction and going smoothly through the rest of the heart, they're getting blocked. So there's unidirectional conduction blockage. And when they get blocked, they sort of bounce off the obstruction. So the owner can conceptualize what's happening so that the impulses, instead of going smoothly from the SA node through the AV node, they're originating at the SA node, and then they're being blocked, and essentially they're bouncing in odd directions. So that's the random entrant activation. So they're going in random directions, in different directions, and so they're activating the atrium at different points. So instead of having smooth contraction of the atrium, you're having a very erratic and very rapid activation of the atrium. Right? And there's a number of things that can cause this blockage and this random re-entry of the electrical impulses. So, a myocarditis or an acid-base imbalance or an electrolyte imbalance. Animals under anesthesia will occasionally develop atrial fib, etc. Even something as seemingly unrelated as foot rot or pneumonia. Anything that can cause inflammation within the animal can, at least in theory, cause atrial fibrillation to develop. All right. Ventricular tachycardia, so as the name suggests, ventricular, so this is occurring in the ventricles versus atrial fib, this occurring in the atrium. So ventricular tachycardia, so tachy means fast, so ventricular tachycardia is a rapid rhythm originating in the ventricles below the bone of His. And again, it's being caused by these abnormal impulses or conduction of the impulses. And again, similar causes, myocarditis, electrolyte imbalances, anesthesia, and so on. So you can have similar causes, sometimes resulting in atrial fibrillation, and sometimes resulting in ventricular tachycardia. As far as the pathophysiology, again, just a very, very, very brief outline of the pathophysiology involved. And I probably already described that. The only thing to make note of is, since you're having these abnormal atrial contractions, you guys remember your cardiac physiology, right? So the atriums contract, and then they load up the ventricles, and then the ventricles contract to circulate the blood through the rest of the body, up to the lungs and then to the rest of the body. So if you're having, erratic or inconsistent or incomplete contraction of the atrium, then you're also going to have erratic, incomplete filling of the ventricles. All right. So what that's going to result in is inadequate blood flow to the rest of the body, and sometimes that will present, for example, as decreased milk production, or abdominal pain, or decreased GI motility. Okay. So you need consistent contraction of the atrium in order to load the ventricles, in order for them to do their job. So if you're having incomplete or erratic contraction of the atrium, then you can see the sequelae that are going to result. Your ventricles aren't able to fill, and so you're getting erratic or inconsistent flow of blood to the rest of the body. All right? Ventricular tachycardia tends to be sustained by ventricular reentry. Once it develops, it tends to continue until you stop it. Sometimes it'll resolve by itself, but usually you're going to have to intervene. All right? So the clinical signs, if the animal is just standing there, you're not asking to do anything, you may not notice any symptoms, but more than likely the history is going to be that the animal is just not doing right. It's not eating and decreased milk production. So the history is going to sound like just about every disease out there. So you're going to have to do your physical exam, and hopefully as soon as you do your thoracic auscultation as part of your physical exam, you'll be able to make at least a presumptive diagnosis. So when you auscultate an animal with atrial fibrillation, you're going to hear that an erratic or irregular rhythm, and there's no underlying regularity, so that's going to differentiate it from the AV block. Remember yesterday we spoke about AV blocks, so there's an underlying regularity, so either you're hearing da-dum, and then a pause with AV block, but with atrial fib, you're hearing, several heartbeats with no regular spacing between them. Okay, so there's no underlying regularity. So that's going to differentiate it from AV block. With ventricular tachycardia, what you're auscultating is just a very, very rapid heart rate. It could be regular or irregular, but the hallmark is going to be very, very rapid. So remember, if you've been out in the pasture with me, I've talked about writing down your normals. So with a ruminant, instead of hearing a heartbeat somewhere in the 60s, 70s, 80s, you're hearing heart rates in the hundreds. Okay, so that's very, very rapid, and it continues. So, and it may be regular or irregular in rhythm, but the hallmark is it's going to be very, very fast. And you'll probably also notice some jugular pulses due to this very rapid and very strong but very rapid contractions of the ventricles and the atriums as well. All right. So as far as your diagnosis, based on the clinical signs of what you're auscultating, so the animal presented with anorexia, maybe decreased milk production, sounds like everything else, but then when you started doing your physical exam, you started doing your TPR, you started listening to the heart, and you notice either this irregular rhythm or this very rapid rhythm. And then in your further investigations, you could see whether there's there's an electrolyte imbalance and so on. But you definitely want to do an electrocardiogram to definitively diagnose whether you had atrial fibrillation or whether you had ventricular tachycardia. So atrial fibrillation, and it's another one of those most common cardiac dysrhythmia of cattle. Yeah, probably atrial fibrillation is the most common. So this is showing you electrocardiogram normal in appearance up here. There's an atrial premature depolarization that you're not going to worry about. But then this strip down here is showing you atrial fibrillation. Note the absence of P waves. There's also fine undulations at the baseline, which you can't see too well on the screen. If you're looking at it in real life, you just see some very fine little jiggling of the line. So fine undulations of the baseline that they call fibrillation or F waves. And there's also irregular intervals between the QRS complexes. Okay. But the hallmark is the absence of P waves. Okay? That sounds like a test question. So absence of P waves with an irregular heartbeat or regular QRS intervals or spacing between the QRS complexes, plus an absence of P waves equals atrial fibrillation. Okay? So that's showing you atrial fibrillation. And ventricular tachycardia. I had to cheat and get this from a human source. Couldn't find an actual animal with ventricular tachycardia. So again, that shows you that atrial fib is more common than ventricular tachycardia. But basically, this is a human, so they have a more positive QRS complex, as you can see there. And then, so normal, and then you start getting these closely spaced complexes, which means that the heartbeat has started speeding up. So this is showing you ventricular tachycardia. And this one happens to be a paroxysmal tachycardia. Wow. 150 to 250 beats per minute. Wow. Anybody ever got their heart rate up that high? Never. Never. I'm a super athlete, so mine is usually in the 60s. It used to be. Not anymore. All right, so that shows you the electrocardiogram for atrial fibrillation versus ventricular tachycardia. And then talking about the treatment, and again, usually I don't try to memorize dosages, but you should at least be aware of what drug to use to treat these cases. So I might ask you, what's the drug of choice? And to treat atrial fibrillation, and you're going to tell me quinidine. And this has been true for decades. Quinidine is a drug of choice, negative inotrope, et cetera, increases ventricular response rate. So basically, quinidine is your drug of choice for treating atrial fibrillation. For ventricular tachycardia, not that it's treatable, but it's not that easy to treat. So you're giving, IV drips with lidocaine or magnesium sulfate. Yes, they're antidysrhythmic drugs. They're so good that you can actually kill the animal by dripping lidocaine or magnesium sulfate. So you got to be very careful. What you would probably prefer to do is try to treat whatever primary disease is underlying it. There's an electrolyte imbalance, so you do your serum chemistry, you see that it's has a deficiency in calcium, magnesium, potassium. So you might want to just give it IV fluids rather than titrating out lidocaine or magnesium sulfate. Yes, lidocaine and magnesium sulfate are the definitive treatments, but you got to be careful, and you got to let the owner know that there's a chance that you may not get it right, and the animal may die. Yes, sir.
Two questions. I know
Two. You only get one.
I'll just put them all together then. In small amount, I know we'll use quinidine also, but can you use like your calcium channel blockers too in your large animal to treat the AFib?
You can, except that it's going to be more expensive, and you get just as good results using quinidine, and it's a lot cheaper. The only case that I could find with a ruminant, a kind of sort of ruminant with atrial fib, was a llama with atrial fib. All right. So I thought that was kind of interesting. So when you guys graduate and become big-time specialists, you'll go on a listserv and you'll spend hours corresponding with your peers and trying to outdo them. Oh no, this is the way I do it. Oh, this is the way I do it. It's always amusing reading it, but anyway. So they had a male llama, appears to be an atrial fib. So the presentation is exercise intolerance. So llamas, they use them for packing, carrying packs on hikes and so on. So this poor guy was probably not doing a good job. So he was presented for exercise intolerance, normal at rest, bright, eating normal. At higher levels of exertion during packing or camping trips, they were seeing this open mouth breathing and collapses. And had been resistant to continue on, okay? So, let's see. So cardiology consult, so there's no significant structural heart disease and classified as lone atrial fibrillation. So that's a human terminology. Basically, it's atrial fibrillation. Does anyone have experience with atrial fibrillation cameras? No. Nobody's ever seen it. Nobody's ever seen a long atrial fib. If so, was it associated with exercise intolerance, or did you attempt cardioversion? Okay? And of course, that is the opinions of specialists in English, not necessarily. Whatever. All right. So the take-home message from that was that yes, they use quinidine. What do you use when quinidine fails? Most of the times it doesn't fail, but yeah, there are alternatives, just like you were suggesting a while ago. Electrocardioversion is not an option. So in humans, they shock and clear and do all that dramatic stuff on TV, but it doesn't work too well with animals. So really, quinidine is going to be the drug of choice for atrial fib. Yeah, so that's all I wanted. Well, yeah. So to answer your question, so what you're getting at with the digoxin, I routinely use digoxin in all of my quinidine conversions. Okay. So, and by the way, they're talking about horses here, and let's see, literature recommends for chronic cases, blah, blah, blah. Both drugs extend the refractory period. Digoxin reduces quinidine-induced tachycardia, blah, 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 blah. So dosages, you don't have to